today. My name is Maureen and I'm a Senior Research and Policy Analyst with the Information and Communications Technology Council, or ICTC for short. ICTC is a not-for-profit national center of expertise that works to strengthen Canada's digital advantage in the global economy. Through research, policy advice, and capacity-building programs, ICTC fosters globally competitive industries and talent. In partnership with our vast network of industry leaders, academic partners, and policymakers from across Canada, ICTC has empowered a robust and inclusive digital economy for over 25 years. ICTC's head office is located in Ottawa, Ontario, which is built on the traditional lands of the Algonquin and Anishinaabe Nation, and I'm joining from Ottawa today as well, actually. And I'd now like to introduce my colleague, Maya Watson, who will be joining us again later in today's event to introduce the next speaker.
Hello, everyone. My name is Maya Watson, as Marie just said, and I am a policy and research analyst for ICTC as well. Today, I'm calling in from Toronto, which is the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabeg, the Chippewa, the Haudenosaunee, and the Wendat peoples. Toronto is also in the Dish with One Spoon territory, a treaty between the Anishinaabeg, Mississaugas, and Haudenosaunee people, and covered by Treaty 13, signed with the Mississaugas of the Credit, as well as the Williams Treaty, signed with multiple Mississaugas and Chippewa bands. Back over to you, Mairead.
Thanks, Maya. In case you're interested, earlier this year, Maya and I worked together with another colleague, Rosina Maloney, on a project about digital transformation in Canada's healthcare system, and the resulting paper was published in August of this year and is available online at ictc-ctic.ca. The report touches on many of the topics that our speakers are going to be talking about today, in addition to the labor market impacts of health technology, tech adoption in Canadian healthcare, and barriers to tech adoption. Now, I am pleased to introduce our first speaker, Shelagh Maloney, who is Executive Vice President of Engagement and Marketing at Canada Health Infoway. Shelagh has held a number of senior positions since joining Canada Health Infoway in 2005. She manages relationships with patients, clinicians, and the federal government, and leads performance analytics and communications and marketing. Shelagh holds a Bachelor of Science in Applied Health Sciences from the University of Waterloo and is a certified professional in health information and management systems. In 2011, Shelagh received the inaugural Women Leaders in Digital Health Award, which recognizes female visionaries who are harnessing the power of IT to transform health and healthcare in Canada. Welcome, Shelagh, and thank you for joining us today. I'm really excited for your presentation, and I'll let you begin. Oh, and you're just muted there. Perfect. Thanks, Shelagh.
Great. Thanks, Maureen. So let me just start by saying I'm really excited to be here, and thanks for the opportunity to come and talk to you about a subject that's sort of near and dear to my heart for sure, is digital health in Canada. So what I thought I would do is I just go through the agenda on the next slide, spend a little bit of time with you talking about Canadians' perceptions of digital health and technology in healthcare. We did quite an extensive research on that, and I think that will inform some of the conversation. And then certainly talk about the current state. Our world has changed since COVID has been declared, and certainly digital health is no exception to those changes. Talk a little bit about the key enablers and how I see that sort of the shifts in that and what we're seeing. Talking about benefits, and I will spend a little bit of time talking about e-mental health services in particular, because I know that's something that's of interest and that will hopefully help inform some of the roundtable conversations later. And then by the same token, talk about opportunities and challenges and where we might go forward. And again, spending a little bit more time on equity issues and social determinants of health. So that's what I hope to present this afternoon, and then we'll look forward to the discussion. So the next slide, let's talk about Canadians' perceptions of digital health. Canada Health Infoway launched the biggest national public consultation on digital health in 2019, just at the end of 2019, called the Healthy Dialogue. And so we asked Canadians, we asked them to sort of take a 10 to 15 year horizon and say, what are the big issues? And how do you feel about technology? And what are your concerns? What are your benefits? And so it probably won't surprise many people on the call that 92% of Canadians want and they're ready for digital health, right? So we have embraced technology in all other aspects of our lives, and now we are ready for healthcare to sort of catch up in that technology. 84% of Canadians said that they would use technology to better manage their health, and they are waiting, and they see technology as helping with some of the issues that we're facing in healthcare today. And 90% of Canadians want technology that puts them in greater control of their health. We want to be able to manage our own health information and do all the things that we know we want to do. And I said earlier that we're taking sort of that 10 to 15 year lens out. A lot of Canadians told us, again, they're interested in AI and robots and things like that, but they really want us to address those first order challenges and things like wait times and having to repeat my health history all the time. So not looking at Jetson style stuff yet, really want us to pay attention to what are the problems immediately of today. So let me we'll move to the next slide and talk about a little bit of the current situation. So obviously COVID has accelerated the use of virtual care. We probably made more progress in digital health in the last year than we have had in the last decade. And I think there's a number of reasons for that. And I'll certainly talk about that. So we went, maybe 90% of all care was delivered face-to-face. And now that number, then we sort of switched that all care at the height of the pandemic, we probably made a switch from virtual care. And now since 2020, about 40% of primary care visits are done virtually. And we'll see, it'll be interesting to see how that number nets out. But there's, I think, three things that I want to talk about that enabled that shift. And one of them is this idea of existing infrastructure. Maya and Mairead explained that I work at Canada Health Infoway. And for those who aren't familiar with our organization, we were established in 2001 by Health Canada. And our mission, frankly, is to accelerate the use of digital care, digital health in Canada. And so we've been at this for 2 decades, right? And so we have electronic health records. We have lab information systems in place. We have drug information systems in place. Canada is an international leader for telehealth. And we have EMRs, electronic medical records, in physicians' offices. And so this 2 decades of work and the progress we've made really accelerated or enabled the switch to virtual care to happen so rapidly. And then the other two I'll sort of talk about together, this idea of a shared purpose and unprecedented levels of collaboration. So, the pandemic hit, WHO declared COVID as a pandemic, and there was a singular focus, right? Everybody was focused on keeping patients safe, keeping the system running. And along with that was, I think, this realization that we can't do it on our own. And so we have to collaborate. So this unprecedented level of collaboration. And I'll just give you one example that I think sort of brings this issue home. So in March 2020, Infoway convened all the digital health leaders from across the country, every province and territory. And we asked them, what are your priorities? What do you need? What is urgent for you to address today? And they told us 4 things. First of all, virtual visits. They needed to have the technology in place to allow clinicians to actually provide virtual care to their patients. They needed to make sure that Canadians had access to their COVID lab test results. They needed to ensure that we had the capacity for e-mental health services. As you know, the demand for that has increased substantially. And then remote patient monitoring. So again, the ability to have COVID patients and other patients, frail, elderly, et cetera, to be able to allow them to be monitored at home to keep them safe. So those were the 4 priority areas that were identified. We made a $35 million investment fund available. And then within 45 days, we had approved 17 projects across all jurisdictions. And one of the stipulations for getting that money was that projects had to be up and running in 30 days. So anyone who's familiar with healthcare knows that that's a very, very quick uptake and turnaround for health. And so what was the impact? 3.5 million Canadians, 91,000 clinicians exercised over 5 million virtual care encounters as a direct result of that impact of that 35 million. And not only that, but this capacity that's been developed through this fund will stay post-pandemic. So there's a really great example, I think, of a common focus and unprecedented collaboration and some nimbleness and ability to make changes happen. So let's go to the next slide and talk a little bit about the impact of COVID on Canadians' perceptions. So I talked about a healthy dialogue. This 58,000 plus Canadians were reached through national surveys and focus groups and interviews and engagement hubs on the web. And we wrapped up this work in February 2020. So then, of course, March 2020, the pandemic hits. But we saw this as a real great opportunity for us. So we had this great pre-pandemic survey results. So we went out again in the spring of 2020 during the pandemic, and we asked Canadians the same questions. And we found that two things changed. Among Canadians, the willingness to use virtual care in the future increased. So you see that we went from 64% to 76%. And that was regardless of whether they had had a virtual care encounter or not. So I think people probably had seen themselves or friends and neighbors or family members of virtual care. So it wasn't sort of maybe as big and scary and unknown as perhaps it was pre-pandemic. The second thing that we saw changed was the concerns over privacy of personal health information actually declined during the pandemic. It's still high. It's still probably and will forever thus be one of the biggest concerns among Canadians. But we saw their concerns from 78% of Canadians expressing serious concern to 74%. So again, quite a bit of a difference there. So that's sort of the current situation. And I should actually mention one more thing. We, in August of 2020, published a survey that we had done in conjunction with the CMA, the Canadian Medical Association. And we found that 2/3 of clinicians were using virtual care, had intended to maintain or increase their use of virtual care, and that there was a great level of satisfaction. So patients like it and clinicians like it. And you see in this graph here, 91% of Canadians who had a virtual care encounter were satisfied with it. We also know 77% of them who had a virtual encounter said it was better or the same as an in-person care. Now, and I want to be very clear about this. When we're saying virtual care is one modality of care. We are not talking about replacing it face-to-face visits. It is one tool in a clinician's toolbox that he or she can use. And it's just a perfect example as in your everyday work, right? Sometimes you want to communicate, you can send a quick email to get your point across. Sometimes you need to pick up the phone and have a bit of a conversation. And sometimes you need to bring everybody together and have a 2-hour, roll up your sleeves session. So again, it's not one size fits all, and it gives us some tools and some options. So let's move on to the next slide, and we'll talk a little bit about the benefits of digital health. And the next slide lists a few of the benefits, and I'll go through them relatively quickly. So the first one is improved access, of course. So you don't have to physically be in the same place as your care provider, and this is especially useful. And we see, Canada has a very large rural and remote population, so we can increase the access to care using virtual care. We also avoid costs. In 2012, for example, the Conference Board of Canada did a study that said if Canadians could only access their lab information online or renew a prescription online, they would save the system would save 47 million primary care visits in a year. So think about that. If you are, a single parent with young children who has a part-time job, who's making minimum wage, and you have a doctor's appointment, well, you might have to take a day off work, pay for transportation, maybe pay babysitting costs, and it's a significant cost saving. So we did some estimates and said virtual care in 2020, the potential and avoided cost was $6.1 billion. That's significant again, and you'll see in the pie chart a little bit where those expenses fall. The biggest one, of course, is time off and productivity, but also there's paid parking and expenses related to childcare and those kinds of things. And then the last benefit listed on this page, patients' access to health information leads to better health outcomes. We know that an engaged patient, a patient who has access to their health information, is better able to manage their care. They're more confident in their care. They understand their care better, and they have a better relationship with their healthcare provider. And so if you have better information, if you are empowered, you have agency to take control of your health, you have better health outcomes. Research shows that undeniably. And better health outcomes, of course, are better for the patient and better for the system as a whole. So continuing on in terms of benefits, one thing that we don't often think of, but there's a bit of environmental impact on digital health and virtual care. And so when you think about not having to travel, and we did some work that in 2020, the estimate is about 325,000 metric tons of carbon dioxide could be avoided if we moved more more virtual and provide more digital care. So like that's significant. 70,000 passenger vehicles off the road. You could provide enough power to keep 50,000 homes and electricity for 1 year. So think about the environmental impact. And then the last one, of course, is improved care for vulnerable and marginalized populations. One example of this is we've done some work with the Cowichan tribe in BC, and they have a community electronic medical record system that they developed by Indigenous people for Indigenous people. And we've helped them roll that out. So now over 317 First Nations communities across 7 provinces have now access to health information and tools that they need to better deliver care. So those are sort of high-level discussions about benefits. And now maybe switching gears one more time, and we'll talk about, oh yeah, so I did want to talk about mental health. I forgot about this. E-mental health services, as everyone knows, the demand has increased substantially. COVID has had a true impact on all of us. And we collected and we asked the Canadians how they would rate their mental health, fair, poor, medium, high, low. And 21% of Canadians told us that their mental health self-described was fair or poor. That's almost a quarter of the population. Think about that. And that's up from 17% in 2019. So we really do need to have increased capacity. And who knows what the long-term effects are going to be and how this is going to continue. And so at Infoway, we've made a number of investments in e-mental health services. And the beauty about e-mental health services is that, sometimes in regular care, if somebody goes in with mental health issues, they are referred to a psychologist. Well, when you have e-mental health, there's lots of tools and technology out there that allow, it's sort of a stepped care model, we call it. And so sometimes it's just you need better tools in your toolbox to help you cope with mental health. But then you've got resources at increasing levels of severity and increasing levels of interaction that help you go through these issues. So I'll give you a few examples. There's a program in Newfoundland called Bridge the Gap. So in Newfoundland, they've had double the number of users from the year before. So they've got 90,000 users in 2020. But Bridge the Gap has also been able to expand their services to Prince Edward Island and to New Brunswick. So again, this great example of collaboration. We do a lot of work with Kids Help Phone, and we help them launch their crisis text line, which is a texting for kids, so no longer just being able to use the phone. And that service has been a tremendous help for young kids across the country. They had about 228,000 texting conversations with young people in 2020. And Kids Help Phone is doing about 5 live rescues a day. So kids who are in serious and immediate harm. And so they have the ability to do these live rescues 5 a day. So imagine the impact that that's making. And when they ask them, a lot of the youth say, what would you have done had you not had access to this service? 40% of them said they would have ignored the problem or they wouldn't have talked to anybody about it. So, that's significant. It's making a big difference. Similarly, there's a similar service in Quebec called Tel Jeune, and their demand has increased 30% through the pandemic. And then Wellness Together Canada is another. So that's if you remember, that's a platform that was launched by Health Canada during the pandemic, just to help Canadians cope. And again, a number of resources are available to Canadians through this methodology. So let's move on now to sort of the next part of the conversation. I do want to talk a little bit about opportunities or some challenges. So I think the healthcare system was quite nimble. And when you think about nimbleness in the health system, it's a pretty risk-averse industry. So being nimble is really important. And so I think a couple of challenges have been identified through this pandemic. And one of them is certainly interoperability. So the ability for systems to integrate and talk to one another, for that information to flow across jurisdictions or across care providers or across care settings. So we haven't quite, we're still working on that. It's a global issue, and that will still take some time and some effort. The other one is the health workforce. So we're certainly seeing headlines about nurses and other care providers just leaving the profession or just being burnt out. So we need to make sure that we can address their concerns. one of the things that we've done is we've just launched a clinical change program. We went out and asked physicians, clinicians, and their support staff, because they're important as well, what would they need to make their virtual care experience more optimal? And they told us three things. They want to get some guidance on the appropriateness, like when do you use virtual care? When is it safe? And when is it the best mechanism of care to deliver? They also told us that they wanted to make sure they had quality encounters. And so what we call website manner is a term that we're using to describe how clinicians interact virtually with their patients and what has to be different. And then the last one is sort of optimizing use of virtual care. So, things like privacy and health integration and those kinds of things. So that's what we've launched for clinicians. And then at the same time, when we talk to Canadians, equity is a big issue, right? Is that we know, and the COVID pandemic has underscored this incredibly, is that we don't have equal access to our health services. And there are some vulnerable and marginalized populations that don't have access. And when we surveyed Canadians, 26% said they don't have access to reliable internet to allow for health technology. 6 in 10 said that they don't feel comfortable. They don't know enough about what apps and services are available to them. And about 40% say they don't understand the health information that's being provided. They don't understand the technology. They're not comfortable. They can't interpret the data. So this whole idea of digital health literacy is a big indicator of equity, and we're trying to address that a little bit. So the next slide talks to you a little bit about a program that we just launched. So it's called the Patient Digital Health Learning Program. It's a week old. We launched it last Monday. And so it's really a program. And what I like about this, there was a real co-design. So we went out to Canadians and we interviewed them. We did focus groups. We did surveys. We looked at environmental scans, best practices, what people were using now, what was helpful now. And they identified 3 things for us in terms of priority areas. So first of all, Canadians want to know more about virtual care. What is it? How do I access it? What does it look like? How do I prepare for a virtual visit? They were also very interested in accessing to health information. So how are you maintaining my privacy and security? How do I access my data? How do I make changes to the health information that I have? And then the third component that what Canadians were very interested in when we asked them about that was how to proactively manage their health. So how do I use this health information to help me better manage my healthcare? And so we took those 3 priority areas. We developed 15 information assets in easy to use formats. So infographics, checklists, those kinds of things. We translated them into 7 different languages, again, to make them more accessible across the country. And now those are available. They're available on the Infoway website. We know not everybody goes to the Infoway website. Only 11% of Canadians know who we are at Infoway. So we're really using our partners to help spread the message. So we'll be in print publications, church bulletins. We're using patient organizations. We're using provinces, and really want to get this word out and make these tools available as widely as we can. So if anyone on this call is interested, I would strongly encourage you to connect and find out more. And so those are that's a sort of a bit of an example of digital health and the current state and what we're using. So I'll just maybe end my presentation there. And thank you for your time and attention. I look forward to the conversation, and I hope some of this information was useful in terms of guiding some of the discussion and informing some of the discussion that will come. So thanks very much. And Maya, I think I'm handing it back over to you.
Thanks so much, Shelagh. That was a fascinating presentation. Before we move on to our next speaker, I think we have a question from Mairead for you.
Sure.
Thanks, Maya. Yeah, great presentation. That was fascinating. And I think it really brought up a lot of themes and findings that we found in our research too. So it's nice to see that we're all kind of finding those similar trends. Yeah, one thing I was curious about is you mentioned that patients having access to an agency over healthcare data creates better healthcare outcomes. And I know that this isn't really one of the things that's been spoken about the most over the last 2 years, but it is something that came up with us with interviewees during our research on digital health was this need for patient access to an agency over their personal health information. So I'm just curious, do you think the pandemic has impacted this in any way? We hear a lot about like the trends towards digital healthcare tools, rural and remote healthcare, but yeah, curious your thoughts there.
Yeah, so I think, first of all, absolutely. And I think I mentioned one of the priority areas is patients, if you have a COVID test, you need to see your lab results. So a lot of jurisdictions have province-wide patient portals. So, New Brunswick, Saskatchewan, Alberta. So as a patient can go in and see their health information. And I think because of the pandemic and people were getting lab result tests or COVID tests, and they were going in and checking, they're actually seeing and accessing their personal health records and their portals. And so when they see that, they can see what's available and what's online and what information is available to them. So I think it's created that extra spark and interest, but it's also increased the capacity for people to be able to access their health records and their health information online.
Great, thank you. Yeah, I guess that makes sense as well. It's not necessarily always what's available to patients, but maybe they need that push to actually start using the tools or like get interested in what's available to them and then make that a habit. We do have one question from the audience, if you have time to answer another one.
Sure.
Okay. So from Alana King, she's wondering if you could talk a bit more about the equity gaps that were highlighted, not so much in infrastructure, but between different levels of government. And then she went on to say federal scope, then provincial, and finally municipal. How can technology smooth the pathway for communication and ultimately services?
Great question. Thanks, Alana. It's a big question. I think, so I think that the equity gaps, I'm not sure that I'm comfortable talking about the different levels of government, except to say, I think it's absolutely recognized across all levels of government that equity is a major issue. And you'll see, I think it'll be a major theme coming out in the throne speech in a couple of weeks and certainly in healthcare. One of the things that when we did talk about to vulnerable and marginalized populations as part of the Healthy Dialogue, we interviewed, people from the LGBTQ communities, homeless people whose English isn't their native tongue. So we got a lot of different perspectives. And one of the things that they told us is, one example was, one of the comments I remember was, artificial intelligence and technology is colorblind. And so those inherent biases would somehow disappear, right? And without introducing bias in the algorithms and the technology, that's a real opportunity for us, is to ensure that we can introduce culturally safe and sensitive care in with the technology and embed it and make sure. And I think those in those more vulnerable populations really saw technology as an opportunity, if used correctly, to be able to address some of those biases that are inherent in the system now.
Great, thank you very much. Maya, if you would want to start introducing the next speaker, would that be?
Welcome.
Perfect timing, there we go.
Hi,
Thanks so much, Sheila. Appreciate joining us today.
Yeah, welcome, Dr. Carrie Barassa. So I will launch right into my introduction of our second speaker today. Thank you so much, Sheila, for answering all of those questions.
You're very welcome.
And for our participants for sending in those questions. If we didn't get to your question, we'll be sure to get those questions to our speakers. Introduction. So Dr. Carrie Barassa is a scientific director of the Canadian Institutes of Health Research, Institute of Indigenous Peoples Health, and a professor in community health and epidemiology at the University of Saskatchewan. She is the principal investigator for the Canada Foundation for Innovation funded Morningstar Lodge, as well as the Cultural Safety Evaluation Training and Research Lab. Dr. Barassa has nearly 20 years of experience as a professor in the field of Indigenous health studies. Through her role as scientific director of IIPH, she leads the advancement of national health research agendas to improve and promote the health of First Nations, Inuit, and Métis people in Canada. Thank you so very much for being here with us today, Dr. Barassa, and I will pass the virtual stage over to you in a moment.
Very good, thank you. Okay. Am I ready to go? Maybe not.
You are good to go. Thank you.
Okay. Hey, wait. Thank you so much. So Brianna is going to help me with my slides. So I'm really honored to be here today. I just want to take the opportunity to acknowledge, actually 2 land acknowledgements. One is I'm from Treaty 4 territory, and I always acknowledge my grandfather who raised me. He passed when I was 19, but I always acknowledge him. So I definitely would not be here without him. But I'm living and working in Treaty 6 territory, which is the traditional territory of the Cree, Dene, Nakota, Lakota, Saulteaux, and homeland of the Métis Nation. I myself am a Métis. My local is in Regina. It's the first Indigenous Riel Métis local, and it's local number 33. So wanted to again thank my local who supports me. And you can see the tobacco ties. Those tobacco ties are medicine, and those particular tobacco ties were originally made for my youngest daughter. I have a 22-year-old and an 11-year-old. They were both born on the same day. And so they both went into ceremony. They fasted. My eldest daughter helped my youngest to fast. And my youngest daughter is now fasting a berry fast. So for a year, she can't have any berries of any kind, even if it's gum or anything like that. And that's ceremony. And ceremony is very, very important in our community. And so having medicine such as tobacco and tobacco ties, it helps to give her strength when she's in her fast. If you want to flip this slide. So today we'll talk about some of the limited resources on health outcomes, social determinants of health, aging, dementia, and technology, virtual healthcare access, community priorities, and some of the work that we've done at Morningstar Lodge at the direction of the communities that we serve. If you want to flip this slide. So when it comes to health outcomes, there really are limited resources. There's inequitable access when it comes to healthcare and health services. And this is a significant contributor to the health disparities that are experienced by Indigenous peoples. So this is particularly true in terms of northern, rural, and remote communities. The geography denotes that there's less access to healthcare. And it's really not only about access to physical healthcare. It also is about access to healthcare when communities are afraid to go to hospitals because they're afraid about systemic racism, discrimination, those kinds of issues. And we'll talk a little bit more about that later on. But within the domain of inequitable access, limited health resources contribute to worsened health outcomes. Rural and remote communities in the north of Canada have a low population densities with large geographical areas. And so it is difficult for Indigenous communities, First Nations communities and Métis communities, as well as Inuit communities as well, of course, to really make it to healthcare appointments, for example, and to make sure that there's culturally safe care. Again, inequitable access is a huge problem when it comes to rural and remote communities in the north. If you want to flip this slide. So social determinants really do impact Indigenous peoples. The cycle of poverty, for example, for Indigenous peoples who face multiple layers of marginalization includes the following: food insecurity, homelessness, lack of reliable health care, feelings of fear when accessing culturally safe, unsafe services. And so it's hard, for example, for Indigenous communities, whether they're First Nations, Métis, Inuit, communities, it's difficult for them to feel safe when they have to go to a hospital or a clinic. Again, when you're isolated and living in the far north, and even if you are in a fly-in community, it's very often that if somebody is flown out, oftentimes they don't have somebody that can go with them. They may not have their first language may not be English. And we see this a lot with pregnant women who sometimes have to be flown out to birth their child, and they may not have anybody with them. So, these are all very unsafe practices. There's also low wages in the North, and a sense of social exclusion and lack of access to clean water, which continues to plague rural and remote communities. If you want to flip the slide. Aging and dementia and technology has been one of the projects that we have worked on at the direction of the communities that we serve. Indigenous populations are aging at a rate of 7.3% compared to 4.6% of the national average in Canada. So you couple that with, the fact that dementia rates are increasing among Indigenous populations, and taking into account that, about 15 years ago, we weren't even talking about dementia within Indigenous communities. And so, however, the lack of access to dementia care and specialists in remote communities is posing a huge challenge to aging in place for Indigenous older adults and families. And there was a time where, the elderly or somebody with dementia, an Indigenous person with dementia, normally they would have had their own relatives taking care of their loved ones who have dementia or aging in place. But now the way that the world has been going is that now families have to work, and so it's much more difficult to get caregivers to come into the home to take care of their family members. So the introduction of culturally appropriate technology can really support Indigenous older adults to age in place by enhancing access to care. Sorry, I don't know. I can't see this underneath there. I think it's just a citation. If you want to flip the slide. So technology and virtual healthcare access is again, really coming along and supporting Indigenous communities to age in place. Telehealth really has the potential to reduce healthcare expenditures, and it's also a way to improve access to care, expertise, interventions, resources, and supports by using video calling, computers, tablets, phones to access remote appointments, as well as online learning programs and supports. And, really, the work that we've been engaging with the communities that we serve, they have been the ones that have come to us to say, we're really interested in telehealth. We're really interested in learning more about technology. And so, we've piloted a number of interventions all around technology. Indigenous peoples that living in rural and remote communities may not have a reliable internet connection. And so we've tried to address this by purchasing boosters. But at the end of the day, we really need better infrastructure for rural and remote communities. And this is really an ongoing issue across Canada. The infrastructure really may render reliable internet. And this is something that we really have to push back on, not only provincial governments, but federal governments, to ensure that we have reliable internet in the far north. If you want to flip this slide. So Morningstar Lodge is an Indigenous community-based health research lab. We place a strong emphasis on community-based participatory research, community partnership, cultural context, and ethical research. And so, we always say that we serve Indigenous communities. That's our role. Our role is not to, come out to the community and say, hey, we have all of the answers and here's the projects we're going to do. That's not what we do. Our mission is to build Indigenous capacity by training, teaching, and hiring locally. And the intent of the lab is to promote Indigenous research methodologies by practicing community-based participatory research. And the lab also promotes supportive environments by creating healthy and reciprocal relationships with Indigenous communities, and all research projects are co-collaborative. So no matter what we're doing, it's always at the direction of the communities that we serve. If you want to flip the slide. So community-based research is an essential Indigenous community-based methodology when engaging in research with Indigenous communities at their direction. So primarily comprised of one-on-one interviews and research circles, Indigenous community-based research can be done in a culturally safe manner. And by training community members to administer interviews, conduct research circles, and analyze their own data. Community-based research also ensures that Indigenous communities truly direct their own research. So for every project that we engage with, we ensure that a Community Research Advisory Committee, or CRAC, is established. And that CRAC is comprised of elders, community members, nurses, health directors, just for an example. And normally the CRACs have 4 to 8 members, and they are the liaisons to the chief and council. So we do meet with the chief and council on a regular basis, but it gives a time, for the chief, because the chiefs are very busy. The chiefs and council are very busy, but the CRAC, because they have appointed who they want on their CRACs, we then can work, with the community and then liaise back to the chief and council. If you want to flip the slide. So in terms of dementia and caregiver support, this is one of the priorities for the communities that we serve. And again, this has all come from the communities. So culturally appropriate technology and dementia care services for remote Indigenous communities are largely unavailable in Canada. And even though caring for elders is seen as a right passed down, there is no funding for training or receiving respite workers on reserve to promote aging in place. And the responsibility is left solely with family caregivers, as I mentioned earlier. So caring for elders or older adults in Indigenous cultures is not seen as a burden to the caregiver. Rather, it's viewed as a privilege and inherent right passed down from generations to continue the cycle of care as those that took care of that younger generation. And it's now requiring reciprocal care to complete the cycle. But again, sometimes sometimes people have to go to work, and so we do need to have folks that can provide care if the family cannot manage on their own. If you want to flip this slide. So in terms of technology readiness, in 2019, Morningstar Lodge partnered with the File Hills Qu'Appelle Tribal Council in a project titled Testing Locally Developed Language Apps to Reduce Caregiver Stress and Promote Aging in Place Related to Dementia in Indigenous Populations. So there's really 2 main objectives. One was to examine the application of language-based apps to persons living with dementia and their effect on quality of life, caregiver stress, and the promotion of aging in place in the context of Indigenous populations. And secondly, to examine the accessibility of language services and programs to cultural survival and retention within Indigenous communities. If you want to flip the slide. So once the data was transcribed and pre-analyzed, it was with the community members utilized a process called NACPA. With this process, the community identified 12 major themes, and they are as follows. Learning language, difficulty using technology, experiences with technology, communication with family and friends, attitudes towards technology, connection with culture, caregiver stress, technology barriers, language app experiences, fluency, distrust of technology, and use of technology. And accessibility and readiness were key factors in the use of this technology. And NACPA is an acronym that was developed, and it's a Cree. It was in what we put it into ceremony at the direction of the elders that we work with, and it was a Cree translation. And we'll talk a little bit more of that in a few minutes. If you want to flip the slide. So in partnership with Star Blanket Cree Nation and AgeWell, Morningstar Lodge was exploring how technology can be used to help manage and monitor multimorbidities that increase the risk of early onset dementia. Indigenous older adults living in rural communities require accessibility to and readiness for new technologies in order to support the monitoring of health data and health status, as well as dementia education. The 2-year project consists of 3 technologies specific to the monitoring of blood glucose, blood pressure, and weight, as well as the delivery of educational workshops concerning healthy lifestyles and wellness. If you want to flip the slide. So we developed the Indigenous Respite Care Toolkit. It's a culturally relevant respite care toolkit for caregivers and loved ones caring for Indigenous older adults living with dementia. So the lack of training, as mentioned earlier, and the culturally appropriate resources available for caregivers of Indigenous peoples living with dementia contributes to the accessibility gap for community-based respite care. Also, the limited culturally safe training modules designed for Indigenous caregivers and family members endeavoring to increase traditional knowledges around dementia. And developing an Indigenous community-based caregiver toolkit for dementia creates culturally safe, accessible resources for community respite care. If you want to flip this slide. So the respite toolkit we developed to increase caregivers' access to dementia-related supports through the distribution of the toolkit and to build capacity for the provision of community-based respite care by creating an opportunity for education, training, and increasing awareness in Indigenous communities. If you want to flip this slide. In terms of addressing health concerns with technology for Indigenous older adults, learning from Indigenous older adults about what they need, how competent they are at using technology, feel and using technology to meet their needs, and increasing older adults' awareness of available resources and services that may help to alleviate any extra anxieties around their health, particularly in this time of COVID. The tablets have been individually tailored to each co-researcher, and bi-weekly workshops run to support learning the device, the applications, and technologies available for the device. And so you can see we've used a medicine wheel. So we have the physical aspects there that include arthritis, diabetes, exercise, medication, diet, COPD, allergies, bronchitis, asthma, eczema, bunions, telehealth, I need glasses, I think, doctor chat, and traditional medicine. And then mental, history, Cree, exercise, diet, sewing, news, reading, cooking, baking, canning, traditional medicine, games, counseling, leadership, sports, gardening, religion. And social is video calling, sports, games, live streams, and emotional is exercise, diet, gardening, traditional medicine, religion, and games. So a lot of crossover there. If you want to flip the slide. In terms of virtual caregiver support groups, working with Dr. Megan O'Connell and File Hills Capel Tribal Council, Morningstar Lodge is supporting this development and delivery of culturally safe care support groups. These caregiver support groups will be co-developed with past and present caregivers of persons living with dementia to ensure that they are culturally relevant and appropriate. And having these support groups virtually also allows for less respite required by the caregivers in order for them to attend. If you want to flip the slide. So that's it for me. The last thing I wanted to say is that the NACPA is an Indigenous methodology that was developed at the direction of the community members, and it's now a train the trainer process, and it has their lens on the outcome of the data analysis. And we actually are developing a NACPA photo. And this has really become quite a methodology that has been taken up by other universities and even as far as Australia and New Zealand. So we're very proud of the work that we've been able to undertake at the direction of Indigenous communities, and also very humbled and honored. So miigwech and thank you.
Thank you so much, Dr. Barasa. That was fantastic. We have about 5 minutes left. Would you mind if I ask you a quick question before we finish up this panel?
Sure, yeah.
All right, excellent. So you spoke a bit about, well, quite a lot about community-based ethical research that you use to serve Indigenous communities. Other speakers on this topic have mentioned the difficulties mitigating power imbalances between the researcher and the people being researched. Did you come across any of these difficulties in your studies? And if so, how did you mitigate them?
Well, I think we've been able to mitigate them because, you know, we have made it so that, you know, we sort of have what we call the big I am, and the big I am is your ego. And so the way that we develop our work is that it's a mentorship lab. And so, you know, everybody has to check their egos at the door and remember what our work is. And our work is to serve Indigenous communities. And so it's really at their direction. And so we haven't really encountered that because of the way that we have developed the lab. You know, the elders that we work with, everything is done in ceremony. So you really have to be, you know, have that humility, and remind yourself, you know, what are we doing here? Who are we serving? And we're not serving ourselves.
Yeah, absolutely. Thank you so much. I think I will wrap up this presentation unless any comments come in with questions last minute. But I just wanted to say thank you so much for your speech, Dr. Barasa, and thank you to everybody who has attended this Smart Health and Wellbeing event funded by Employment and Social Development Canada. So this is the 5th in a series of events dedicated to an inclusive and smart economy in Canada. And for those of you who sent in questions that we weren't able to get to, please reach out to Mairead or I, and we will work on getting answers to those unanswered questions. Once again, I would like to thank Shelagh Maloney and Dr. Carrie Barasa for your insightful speeches. And it has been an absolute pleasure listening to you today.
Thanks so much.
Thanks so much.
Thanks for having me. Take care.
Bye, everyone.
Bye now.
Bye-bye.